Although the hour is already very late, I want to talk about endothelial and vascular function. My conflict of interest with Medtronic and speaking fees with Baxter are not related to that talk. Regarding vascular function, I had an eye-opener. We performed a study comparing in a randomized way balanced crystalloid with balanced colloids. And we did the titration of the fluids based on stroke volume measured by esophageal Doppler monitoring. So we guided the fluids based on stroke volume. And there, in this group, we have seen that colloids were able to maintain stroke volume. That's the other diagram. And crystalloids couldn't do it. So there was a significant difference in flow, but this was not related to fluids. The fluids were more reduced in the colloid trial. Okay, this was a quite successful trial. It was well seen, but why I show you these things? Because then during the analysis, I showed to myself the intraoperative fluid balances, and it's horrible. We have IV solutions we give to the patients. We had the transfusions. We had urine output and blood loss as fluids going out. But the fluid balance was massively positive. And the striking thing was, if you look at the data, and it's from minus 3,000 is an outlier because the patient had ascites and it was a short operation. But this is striking. Nearly every patient has a massive positive fluid balance. Okay, you can say fluid administration too liberal, but this was titrated based on stroke volume. This was the high-end treatment algorithm for hemodynamic care. So this is the point where the surgeons always say you're too liberal. Yeah, you give too much fluids. And this is something that made me think many years, and I was thinking, where's the problem? Where's the fluid going to? And now we come to the vascular and endothelial function. And if you look at the endothelial function as effector of vascular properties, we have these four characteristics they mainly cover. The regulation of vascular tone, maintenance of vascular barrier, and additionally, cover the inflammatory response of the tissue and the coagulation. And I want to talk about regulation of vascular tone. What does it mean? It's a so-called flow-mediated vasodilatation. This is an issue mediated by the endothelium to cover vascular function. The tissue with higher metabolic demand, they induce a microarterial vasodilatation that leads upstream to an increase of flow velocity of the blood in the vessel. This increase of flow is detected by shear stress, mechanoreceptors, and then eNOS is induced and NO induces vasodilatation. This is a function used in cardiology for many years. For many years, they know that the effect of that flow-mediated vasodilatation is directly associated to your vessels being healthy or not. If you have a reduced flow-mediated vasodilatation, you have an increase of dying the next years. In cardiology, a well-established prognostic factor. Okay, we did. In this study, I showed you colloid versus crystalloids. We analyzed that. We analyzed that by tissue oxygenation measurements, and we combined it with an ischemia reperfusion protocol. And if you induce ischemia, the tissue oxygenation is falling. The faster the tissue oxygenation is falling, the worse is the vessel density and the supply of the tissue by blood. And we could see that during the surgery, although being treated with Doppler algorithms, with standardized norepinephrine application, continuously this saturation slope declined in this patient population. Then there's another factor, the recovery slope, the ability to dilate, to cover the metabolic demands developed during ischemia. And the steepness of that slope is an indicator of healthy endothelium. And we could show that this substantially declined with every hour during surgery. So we have an endothelial impairment up for patients undergoing surgery if the inflammatory trauma is big enough. Interesting, in this study, we showed additionally that norepinephrine requirements the patient developed within their treatment algorithms was highly associated to that desaturation slope and to the recovery slope. So the norepinephrine requirements within that goal-directed hemodynamic algorithms was associated to endothelial dysfunction. Heart rate for the desaturation slope, yes. For the recovery slope, not. So we have a microarterial problem and the regulation of vascular tone. That means it decides where's the blood going to, and if the body cannot match the demands to the supply, then we have a perfusion problem. Okay, the next thing is maintenance of vascular barrier. Many times I hear, okay, the patient is leaking, yeah, the fluids are going out, yeah, you cannot do anything, just give fluids because the fluids are going out and the patient develops a capillary leak. Okay, for that I did a study I'm about to publish these days, and we established a methodology for using that in the perioperative course. And in this study, based on an esophageal Doppler monitoring algorithm, we could repeat the same numbers of massive positive fluid balance. These were healthy patients, cardiovascular healthy patients, undergoing gynecological tumor resection due to ovarian cancer. And then we did this, what we adopted from phlebology to analyze the vessel functions in the legs. And what does it do? You do a cuff that goes to 60 millimeters of mercury, and then you have an arterial inflow and no venous outflow. And then you just look at the volume of the limb. How is it developing over time? And if you look at the point, then the steepness of the arterial inflow at the beginning is the same what I analyzed in the previous study, that it's an endothelial ability to vasodilate due to the increased demands. For that, I could show the same as in the previous study. You have a steep decline of microarterial regulatory function to match the supply with the demands. But the good thing is it recovers fast after surgery. The time point 2 in the PACU is approximately 4 hours after surgery, so it's a fastly recovering process, the microarterial function. But I could repeatedly show that it was there. The second part of the protocol, from minute 3 to 6, and we published this methodology, is the extravasation not be induced by vasodilatation. It's like the capillary leakage, the vascular extravasation. And this, if it's continuously increasing, then you have the situation that the vessels are not realizing their barrier function like they should. So they are leaking. If it's not so steep, then you can say, okay, they maintain their barrier function. And then we analyze that, and everybody thinks, okay, they should leak because they have a massive positive fluid balance. And what we could see is there was no signal. There was no increase of leakage in the perioperative course up to the 3rd postoperative day. So in this study there, the patient having not shown capillary leakage. So where's the fluid going to? And if you look at the distribution of blood volumes in the different vessels, you come to the point that only a very small part, approximately 15 to 17%, is in the arteries. That's what we can measure. But nearly 70% of systemic blood can be found in the veins. The blood is in the veins. And how about their function? The veins have the possibility to conduct blood as a pure blood conductor, that's in muscles, heart, brain, but they have additionally the function of being a blood reservoir in the splanchnic and the skin areas. And there is pooling possible. How does it look like? You have an intravascular pressure. Yeah? If the veins are depleted, the veins are collapsing. Yeah? And then you have no wall pressure, and there's no flow because you don't have pressure, you don't have returning pressure, the blood is not coming back. Then it's increasingly filling up, and if you distend the veins, then there's a force pushing back the blood to the heart. It's a positive. This is an analogy of different models where you have an inflow and outflow, and you need a certain filling of veins to be able that there's a flow out of the veins, the venous return. And up to the point the outflow is reached, we have the so-called unstressed volume, and from that point on, you have the issue of stressed volume. So we need stressed volumes in the vein to have a venous return, to the blood coming back. But what happens in our patients? The problem is we cause vasodilation, by our anesthesia, by the epidurals, and the inflammation causes vasodilation too. The problem is we measure the vasodilation in the arteries, but it is shown that the vasodilation in the veins are sometimes even more important. It's even worse if you use volatile agents. So if you cause a vasodilation, the tension of the vessels, of the venous vessels decreases. You decrease stress volume and you decrease venous return. You induce venous pooling. And this is something very important, and this is something what happens if we compare it with the similar thing with the inflow and the outflow. We induce that the width of the veins are increasing, and that takes away the backward pressure of the veins. And this is really the problem, because if you don't have stressed volume, you don't have venous return. And this is something you can see there. You need tension on the veins to bring the blood back. If you don't do it, what happens? The veins vasodilate. They cover 70% of the veins. The stress volume decreases. The cardiac output decreases. What I did in my study without knowing, I gave fluids, and I gave more fluids because the cardiac function showed me the heart is empty. And at these days, I was not so aware. The good thing is that the study was more or less controlled for vasopressors, and there was a little bit of tonization, but today I would do it differently. I would do it more consequently, tonicized by a vasopressor, the vessel function, to get the blood coming back to the heart. And how about different vasopressors? There are only very, very, very few data out there. This is a very old study, and they could show that the concentration response curves for vena safena in vivo was 2 logs higher for norepinephrine than for phenylephrine in this case. And this is very important because norepinephrine is the strongest vasoconstrictor on the venous side too. And that's why I always, to be honest, you can attack me, I introduce every anesthesia with norepinephrine to tonicize the veins, to cover the vasodilation I induce with the induction of anesthesia. And the worst thing in this context is vasopressin, because vasopressin has no effect on the veins. It's just purely on the arteries working. So coming back to a summary, microarterial reactivity as an expression of endothelial function deteriorates intraoperatively continuously, but it recovers within hours postoperatively. This is something we have to be aware that the blood is flowing sometimes in the wrong direction. The distribution of cardiac output is a future issue for myself. Vascular extravasation cannot explain the positive fluid balance. That's what I found in the study. And then venous dilation might be a possible explanation for blood volume expansion. Yeah, we expand the volume being in the veins, and increasing vascular tone, for example, by norepinephrine, might be a rational approach. Thank you very much.
Very much, Aarne, for your talk. You mentioned nitric oxide and the effects, the changes in it with the perioperative period. A number of the interventions that we do are trying to reverse those changes, but none directly target the underlying physiology. Do you think that's an area that we'll see change in the future?
Personally, I don't think, because the problem is it's a local phenomenon and you cannot systemically approach that. I think we have to do whatever it takes to maintain physiology. That's my personal opinion. The problem is, I don't know, for erythrocytes are NO scavengers. Yeah? So the reason if you transfuse red packed cells, the blood pressure goes up. It's not that you increase preload, you're taking away the NO, yeah, to reduce vasodilation. Yeah? So, but this is a general effect. And we know if we do it too fast, there might be a hint that this is not favorable for patients. So we have to, I think it's a purely local phenomenon that cannot be controlled systemically. So I don't see that there's any approach in the future coming, or in the near future coming, to regulate that. That's my personal opinion. Killed I the monitor, or?
While they're just setting up for the next speaker, can I just ask a question? Linking back with Manu's talk really, I mean, do you think there's a role of the endothelium in perioperative acute kidney injury?
Yeah, for sure. The dysregulation of NO, the dysregulation of microarterial blood flow distribution is a very crucial thing. And if you then combine it with venous dysfunction, yeah, that's the regulation that's going bad. We have to find the balance between, yeah, how to regulate that back, I personally think.
But then if we link from what Manu said in his talk, we keep the venous pressure low, which is ideal because that's a norm physiological, and we give vasopressin because that can keep the arterial pressure up, but that doesn't work. So what's the explanation for that?
Yeah, the point is, I think it's an issue of quotes and balance at the end. Yeah, you have to differentiate the different situations. Yeah, I personally think that vasopressin causes. Yeah, we discussed that 2 years ago when we were challenging each other in a podcast. The point is, yeah, we have to combine it with cardiac output monitoring. If we want to come to the point, balance this approach and my approach, then the decision key would be cardiac output increasing or decreasing. If you use vasopressin and cardiac output decreases, then for me, there's no rational. If it's maintained, it can be a rational. Yeah, and this is something very crucial. I think that if we want to differentiate these states, we have to think about cardiac output. But I'm open to fight.
I don't think we have time for that, unfortunately.
There's one quick question from the floor, if that's okay.
Okay.
You mentioned your use of noradrenaline perioperatively.
What?
You mentioned your use of noradrenaline perioperatively, and they're asking if you could tell us a little bit more about how you're using that, what doses you're using it at.
Yeah, to be honest, what we found in our studies is that 0.05, for example, norepinephrine micrograms per kilogram per minute is without any problem associated. I came to my own analysis that I didn't publish to the point. The limit for harming or when you have to take care of norepinephrine dosage is 0.1 up to 0.2. Something in between these two doses. At that point, the detrimental effects of norepinephrine starts to increase. That's what I've seen in my studies, but that's not something I published. Sorry.
Perfect. Thank you very much.